Good evening, everyone present here. I am Faraz from IGCP. Welcome all the participants on very important case-based discussion. And for this case-based discussion, let me tell you the topic for this discussion. It is acute hepatitis A with kidney injury, a challenging case-based discussion on the occasion of World Hepatitis Day. And for this, we have very eminent speaker, none other than Dr. Harsh Udawat sir. And let me share some of the achievement of sir. Sir has done DM in gastroenterology, PGIMER Chandigarh, director and head of Department of Gastroenterology and Liver Sciences. And we have another case presenter. She is Dr. Nisha Gaur ma'am. She has done DM Nephrology, SMS Hospital, Jaipur, Consultant Department of Nephrology, Eternal Hospital, Jaipur. So both will be the presenter for case discussion. First, I would like to hand over this session to Dr. Harsh sir. Sir, over to you, sir. You can proceed with your presentation.
Yeah, thank you so much. So today we'll be discussing uh, a very challenging case. These are common cases. However, these can be very challenging, and particularly when you face a young person or an adolescent, uh, where you need to uh, pull in various other specialists and even certain treatments that are not present in your hospital, and you may need to refer the patient to a specialist center. So let me present this case. This patient presented to us around midnight on 18th Feb 2025, and this was a 22-year-old male, and he presented with fever for last 4 days. So this was a febrile illness reaching up to 101 degrees Fahrenheit. The fever was intermittent. There was no chills and rigors, and this fever lasted for 2 days, and it spontaneously resolved. It was associated with weakness, nausea, fatigue to begin with, and there was no history of cough, dyspnea, chest pain, dysuria, or diarrhea. There were no joint pains either. Uh, After 2 days, the patient noted that his urine was pretty dark in color, and the family members noted yellowness of eyes. He started to vomit, and for 2 days there were two episodes. It was non-projectile, bilious, small amount, but no blood. So he was admitted in our general ward, and since he had um, an LFT report that showed that his SGOT, SGPT were in thousands, we thought that this would be acute hepatitis, probably viral hepatitis, and we admitted him. In the morning, he complained of epigastric pain, which was moderate in intensity. It was burning in sensation with lots of fullness and a vague feeling in the lower chest. And this was non radiating, and he was very uncomfortable. And he also gave a history that he hasn't passed urine for 12 hours. And during his workup and in the emergency, we noted that his pulse was 110, his blood pressure was 101 by 60. He was afebrile at that time. His respiratory rate was 18 per minute. His oxygen saturation was normal. He was fully conscious and oriented. There was no pain on 18th night. And EMV was good. There was no evidence of encephalopathy. And the score was EMV score was 20 by 20. Neurological status, there were no flaps. He was fully conscious and oriented. There was icterus and the sugar was good. And on 19th, you can see that his respiratory rate here was 20, and his L and his I were working. Although his chest was clear, he had 99.3 fever. Oxygen saturation was good. He had slight pain. It was moderate in intensity. His abdominal examination was soft and non-tender. The chest was clear. There were no flaps. The icterus was present, and the sugars were normal. And this continued over the next 2 3 days. And then we ought, we reviewed the investigations, and you can see here that his hemoglobin was all right. His counts were normal. Platelets were 1.75. He had jaundice, predominantly conjugated or direct reacting. Look at the AST 16,080 and ALT 7,086. Now we asked him whether he has taken some paracetamol accidentally or, I mean, for some suicidal intent, but he denied that. His alkaline phosphatase and GGT were mildly raised. Albumin was slightly on the lower side, and he had coagulopathy. PTINR was pretty high. His creatinine was 3.7. His LDH was high, and his ammonia was normal. His urine routine showed proteinuria, and the granular casts were seen. Sonography was suggestive of hepatomegaly, and there was no evidence of chronic liver disease. And look at this, uh, his counts increased on the second day of his admission, where we had to consider sepsis, and we sent blood cultures, urine cultures that were negative. And then after giving antibiotics, this reduced, this came back to normal. Platelets were normal. Bilirubin, you see that it is increasing, right? And it reached up to 14.7 till discharge. AST, ALT gradually decreased. Albumin also went down. PTINR reached up to 5.03, and luckily it went down gradually. Creatinine, you can see here, 3.75, 6.5, 4.66, increased to 6.8 and 7.74 during the course of his illness. He had low potassium during his admission, and we had to correct it. Later, the proteins became trace, and his cast was nil. So, such high OTPT, and with coagulopathy, without encephalopathy, I think the first diagnosis everybody will put would be an acute viral hepatitis. Now we wondered, why is it that SGOT, rather AST, is more than ALT? And then we reviewed and found that in the initial stages of acute viral hepatitis, AST may be more than ALT. So this went pretty well with the diagnosis of acute viral hepatitis, and later the ALT was much higher than AST. So we got the workup for severe acute hepatitis, and we found that he had IgM anti-HIA positive, E was negative, HbSAg, HCV negative. Tropical workup was negative, except for leptospira serology that was positive. During the course of illness, we also got ANA and anti-SMA done because he also had renal failure, and that was negative. Now, treatment, we asked our nephrologist, Dr. Nisha Gaur, to see the patient, and we shifted the patient to ICU. We gave him IV fluids and albumin, injection terlipressin, IV antibiotics, injection ceftriaxone was started, and later shifted to injection meropenem. And we thought that we should also treat IgM positive leptospira. Injection Keysol was given to correct potassium, vitamin K for the coagulopathy that he had. Meanwhile, we had counseled the patient because he had pretty high uh, coagulopathy. So we had asked the patient to consult a liver transplant center. We referred him to another hospital that we have, and we talked to the liver transplant surgeon, and he also said that I think we should go in for CRRT at this stage and wait and watch. They had also consulted another liver transplant center in Delhi, and they also agreed that right now I think he would be able to be managed with only CRRT or dialysis. And I would hand over now to Dr. Nisha Gaur, who is a nephrologist, and we took her help in managing this patient. So, Nisha, all yours.
Good evening, everyone, and thank you for having me here. At the time of reference, when I saw the patient had a very low volume of urine. It was less than 100 ml urine output since 6 hours, and his creatinine was 3.7 milligram per deciliter, but with normal electrolytes. And there were no signs of volume overload, no hypotension, BP was absolutely fine. But in view of decreased urine output, we shifted the patient to ICU. And even after fluid resuscitation, we gave fluid of 2 liters on the floor only, but there was no adequate urine output. So, in ICU, to keep the mean arterial pressure more than 75, we started him on low dose of inotropic support. That was noradrenaline infusion. We started at 2 ml per hour. And ABG at the time of ICU shifting was the lactates were rising at that time. It was around 4 and bicarb were 19. So patient was started on fluid resuscitation as well as injection albumin as albumin was declining in view of acute liver failure. And even after resuscitation, patient was not having adequate urine output. So we started him on low dose of diuretic infusion. That's what we call LASIK challenge. And with this, patient's urine output improved to 50 to 60 ml per hour. In day 2 of ICU, patients had no symptoms of volume overload. There was no symptoms of uremia. There was no hepatic encephalopathy. And but inotropic support has risen to 5 ml per hour. NORAD infusion was on 5 ml, and urine output was static. It was not inclining, neither declining. It was around 50 ml per hour, but creatinine was 5. It had risen significantly, and electrolytes were normal. There was no hyperkalemia, no hyponatremia as such on the day 2. Lactates were declining with fluid resuscitation, and bicarbonates were 20 with the help of injection sodium bicarbonate. So, patient was counseled for CRRT on day 2 of ICU because the and on day 3, what happened that inotropic supports were there at 5 ml per hour, but the urine output declined significantly. It was 30 ml per hour. They lost creatinine at multiple.
You are not audible. There is a break in your
Yeah,
audio. There is
I
a
think
break
there
in
is
your
still
audio.
error.
Yeah, there is some problem with the audio. So I think on day 2 of ICU, we counseled the patient for CRRT, and considering the cost and considering that it has to be given for a longer time, we always counsel the patients for CRRT, and this was in view of the rising creatinine, persistent lactic acidosis, liver failure, and urine output to less than 30 ml per hour. And the inotropic support was already there, so albumin was started. We had already stopped injection terlipressin as we had shifted the patient to noradrenaline, and IV fluids were now stopped. Is your audio okay, uh, Nisha? So on day 4, the CRRT was continued. Creatinine came down to 4.66 with correction of lactates to normal, and inotropic support started to decline. Patient's total urine output remained less than 500 ml in 24 hours, and CRRT was continued for 72 hours. Day 6, patient maintained BP without inotropic supports, diuretic infusions were tapered, and patient's urine output came to around 1.5 to 2 liters in 24 hours. And so the decision was taken by Nisha to stop CRRT. However, because the patient was, although he was throwing good volumes of urine, in the recovering period, there was slight increase in serum creatinine and it went up to 6. And patient needed 3 intermittent hemodialysis before discharge in the recovering period. So this patient uh, required significant amount of renal replacement therapy, and the diagnosis probably was ATN in this patient. Nisha, are you there?
Yes, sir. I have
Yeah.
rejoined. I think there is
Yeah.
some
Okay.
issue with
Okay.
network.
Okay. So, if you could kindly tell us, I've already, in view of time, I've
Yes, sir.
already
Yes, sir.
taken.
Yes, sir.
Yes, sir. So,
You have
anything you want to
already
add before
discussed.
discussion? Yeah. Anything you want
No,
to say
sir.
before
So
discussion?
as we are seeing that initially the fluid resuscitation and BP maintenance is very important in initial 24 to 48 hours. We gave fluid resuscitation, we gave diuretics, maintained the BP, and in view of rising creatinine, volume overload, and rising in bilirubin, we started CRRT therapy. After 72 hours, patient urine output started pouring, which sir has discussed, and there was no indication as such of CRRT. So we stopped the CRRT, and in recovering phase, of course, there is need of intermittent hemodialysis, which we gave him. So, sir, you can continue with your discussion first, and then we can continue with mine.
No, no, you go ahead, please, because I think AKI
Okay.
is an important part. So you
Okay.
continue. Yeah, yeah,
Okay.
yes.
So acute kidney injury is a prevalent occurrence in individual with ALF, which is approximately 40 to 80% of the cases which have been recorded throughout the world. So US and UK have said that they have incidence rate of 40 to 80% of cases. But in Indian context, we have seen many articles and they are generally depicting very lower frequency ranging to 3 to 10%. So it can be because of underreporting of the cases, which we are saying that we should report more. And also the comparatively prevalence of AKI, less prevalence was attributable that the paracetamol induced ALF was more in Western region and we had more of viral related hepatitis and acute liver failure. So what were the risk factor of AKI found significant among ALF patients in multiple studies? One is age, younger age and elderly were more affected. And a high day 3 lactate, which we have discussed in our case, that our lactates were rising on day 2 only. The lower sodium initially, gender females are more getting affected than with AKI than males. And the criterias which has severity score of acute liver failure, low hematocrit, the TNF value, which is a cytokine which has been released in the in because of damp and because of hepatotoxic cytokines which are getting released, the TNF level. However, we can't monitor the TNF level. It is in studies only. The presence of shock. We are having SIRS in generally in acute liver failure patients, which leads to shock. And these all are the main significant factors, risk factors, which are responsible for predicting that patient will have AKI in near future. So next, you need to change the sorry. So we have two definition. One is persistent AKI and transient AKI. What is persistent AKI? If the if renal dysfunction is persisting more than 48 hours, that is because of it is an independent factor associated with diminished short-term transplant-free survival. And transient AKI, if AKI has recovered within 48 hours, so that did not exhibit such an independent association. It can be categorized into four acute kidney injury. The primary is pre-renal, that is because of hypotension or hypovolemia. Second is hepatorenal syndrome, which we say as in cirrhosis patient also, but here there is systemic vasodilation rather than splenic vasodilation. Uh, third is intrarenal, that is most common, which in our case was also the diagnosis. The common thing is acute tubular necrosis. Our diagnosis was also ATN. And the rarest thing is post-renal, that there is some kind of obstruction in ureter or bladder. So, what is the definition of AKI? According to KDIGO, we have guidelines that serum creatinine is rising by zero point 0.3 milligram per deciliter within 48 hours or increase in serum creatinine more than 1.5 times baseline within 48 hours or urine volume is less than 0.5 ml per kg per hour for 6 hours. Other categories we do not need to see, that is for nephrologists, but for gastroenterologists, the thing is that we need to see even zero point 0.3 milligram per deciliter of rise is AKI and we need to be cautious initially. Next.
So in this patient, I think this falls in the stage three, as there
Yes,
was
sir.
an anuria for more than 12 hours, and
Yes, sir.
the urine, the creatinine also increased to more than or equal to 4.
Yes.
And these are the patients that would generally require renal
Renal
replacement
replacement therapies. Yes.
therapy. Yeah, and we
Yes.
also saw that we tried for even we added terlipressin, albumin. We tried to give fluid challenge, that did not work.
So these are AKI HRS criteria, which I think they are not actually to be discussed in AKI
Yes,
cases. Yes.
yes.
So, what are the main reasons of AKI in ALF patient? First is hemodynamic instability that can be pre-renal AKI, HRS, and AKI which persists to ATN. So, what are the things responsible? First is the volume depletion because patient is not eating, patient is nauseating, he's not eating properly, not taking orally. So, first thing is volume depletion that we treated with volume resuscitation. Second is because of sepsis, bacterial or fungal. There is translocation. There is, we have seen that PAMPS related things, which leads to inflammation and SIRS syndrome. Third thing is SIRS syndrome, which we has discussed previously, that because of DAMPs, like damage associated molecules, and PAMPs, because pathogen associated molecules, there can be a systemic inflammatory response. There are high cytokines, high TNF, which can lead to peripheral vasodilation and shock in these kind of patients. And fourth is direct nephrotoxicity, which is more common, or it is also common in young patients in India also. Because of glutathione depletion, there can be direct toxicity of paracetamol to renal tubular cells, which can lead to ATN. So this diagram, next. So this slide, next slide, is very important for each and every person. If we are dealing with acute liver failure, we are seeing there is liver injury, abnormal liver test, coagulopathy, INR more than 1.5, as well as hepatic encephalopathy that defines our ALF. We need to see at the creatinine. If we have baseline creatinine, like in this patient, the creatinine was absolutely normal 10 days back, or 1 month back, sorry, because he got his routine test done. So it was absolutely normal. We had history that the creatinine was normal. And we are seeing that it has risen to 3.4, or increase in the serum creatinine. I have discussed there is decreased urine output. It was patient was anuric for 6 hours. So diagnosis of AKI should be made initially. Initial measurements, what we need to take. Correction of hypertension is very important. What we did, we resuscitated the patient with 2 liters of IV fluid. We maintained his BP, mean arterial pressure, with inotropic support, and we gave him injection albumin. So we resuscitated the patient first, and with this, we need to have this in mind that we need to look for volume overload sign. We are resuscitating, but we need to have that in mind. We should not push the patient for pulmonary edema. So we were looking at IVC, we were looking doing POCUS regularly of that patient, and we were looking at chest X-ray and saturation of the patient. So there was no sign of volume overload until the day 3. Second thing, treat the infection. As we can see, the TLC was rising, but cultures were negative. We started IV antibiotic. Initially, patient was on monocyte, and then we switched to meropenem. Third, avoid nephrotoxic drugs and contrast agent. That we need to know that NSAIDs should not be given this patient, and we avoided all that. What were the specific therapies? N-acetylcysteine for paracetamol related thing, which was not needed in this patient. Renal replacement therapy is very important. So, why we preferred CRRT, continuous renal replacement therapy, in place of hemodialysis? Because it is medically indicated. What happens in CRRT that the hemodynamic changes are very slow. So they do not cause any rise in intracranial tension or hemodynamic instability in patient. Every correction is very slow. Also, normal hemodialysis do not remove ammonia as Instead, CRRT removes ammonia level in comparison to plasma exchange therapy. So CRRT is always better in these patients. While as in normal patients which are not with acute liver failure, we generally prefer CRRT in very hypotensive patients. If patients are not tolerating hemodialysis, we go for CRRT. But here the picture is very different. So in acute liver failure patient, we always prefer CRRT because first thing, they are changing the concentration of electrolytes or BP change are very slow. Patient tolerates well. Second thing, the molecular size which CRRT is removing is very high. So CRRT can remove the cytokines, the inflammatory marker, the TNF, which are responsible for SIRS. Third thing, it removes ammonia level, which is not possible with hemodialysis. Another thing is liver support therapy with CRRT in form of either plasma exchange. Am I audible, sir, or I'm
Yes,
disconnecting
yes,
in
yes,
between?
yes. No, no, you are audible. Please go ahead.
And the last thing is liver transplantation. If the patient is not improving with all these things, then we need to go for liver transplantation.
Yeah, I just wanted to add one thing, that N-acetylcysteine is commonly used in India, and we also use it sometimes in non-paracetamol related ALF. However, since we started renal replacement therapy, and the use of N-acetylcysteine needs to be doubled when the patient is on dialysis or renal replacement therapy, so we thought renal replacement therapy would be a better modality, and we did not add N-acetylcysteine in this patient. Liver support therapy is not available. It's with us, and
Mars
it
and all things are not available, sir. Yes.
yes. So it is recommended in research settings. Liver transplant, we had already referred the patient, and they had seen two liver transplant surgeons. And since there was no encephalopathy, I think renal replacement therapy was more important, and we were monitoring the patient for any hepatic encephalopathy that develops. We are also monitoring with prothrombin time, and it was gradually decreasing, and in 3 or 4 days, it came to normal. So I think liver transplant was not indicated at this moment in this patient. Yeah, Nisha, please go ahead. Nisha, are you there? Are you there, Nisha? Yeah, Nisha, are you there?
Sir, I'm having again
Yeah, yeah.
trouble in
Acha,
connection,
no
but I
problem.
can see. I can
Yeah,
see
so I
that
think yes.
plasma exchange. Yes.
So please tell us what is the difference between plasma exchange and CRRT?
So plasma exchange, sir, we are removing the plasma and replacing it with either albumin or generally we prefer plasma. And plasma exchange has a more larger pore size. So it will remove all the cytokines, endotoxins, bilirubin, bile acids, ammonia, aromatic amino acid. But it will not decrease the creatinine because we are not doing dialysis. So when patient is having acute renal failure along with acute liver failure, generally we prefer CRRT. Why? Because CRRT can remove also cytokines, bilirubin, ammonia, as well as it can decrease creatinine and maintain electrolyte dyselectrolemia also. It also can correct metabolic acidosis, which is not possible with plasma exchange. So we went for CRRT in this patient because all those things were present in our patient. Although a CRRT and someone will ask that why we are not combining TPE, total plasma exchange, with CRRT. So both are costly therapy first thing because the cost will increase very exponentially in both the therapies. Also, there is no head-to-head trial which can say that one is better from another in view of removal of ammonia. So for ammonia, if we are prescribing only for ammonia, that patient is in ALF and we need to remove ammonia only, then there is no head to head trial which one is better. So we better go for plasma exchange. That is also high volume, which is 15% of ideal body weight. Generally, it goes to 8 to 10 liters of plasma exchange every alternate day for at least 3 plasma exchange. Combination with other extracorporeal therapy, which we have seen that these are not generally available at present in our hospital or anywhere else. I have no idea about, but generally CRRT does the work. And if we are very desperate that ammonia is not reducing, then we can combine the CRRT with plasma exchange.
So thank you, Nisha, and I'll tell you the follow-up now of this patient. So this patient, you can see here that uh, he was pouring good volume of urine. AST, ALT had come down. Bilirubin was rising. You can see here that it's rising, but AST, ALT decreased. PT-INR was normal. Creatinine came down to 2.34. And since he was hemodynamically stable and the urine output was normal, but no signs of volume overload, we discharged the patient. And we discharged the patient on oral antibiotics, laxatives, oral PPI, ondansetron, supportive care. And we asked the patient to come up for follow-up every week. Now, interesting thing happened that on follow-up after 10 days, he had significant pruritus, and for that we had to prescribe him hydroxyzine and cholestyramine. And the jaundice was also increasing. He had icterus that was darker, and urine color was also dark. And yes, today only the patient came for follow-up, and he has mild pruritus. He has stopped hydroxyzine or Atarex, and he is continuing cholestyramine. Now, these are the bilirubin levels. On 11th of March, he had 20.8. It had gone up to 20.8, but is now gradually decreasing, and it is 6.36 2 days back. OTPT are returning to normal. ALP mildly raised. Albumin is now normal. Prothrombin time had returned to normal and continues to be normal, and creatinine is now gradually decreased to normal, and his urine output is good. So the final diagnosis what we kept was severe acute liver injury secondary to hepatitis A with AKI ATN. Now we cannot label him as acute liver failure according to EASL because there was no hepatic encephalopathy ever. So we are using the term acute liver injury here. Patient had coagulopathy, jaundice, and no hepatic encephalopathy. Uh, this is he's also slightly unique in that he also has cholestatic jaundice, and this is a variant of hepatitis A, that the pruritus and jaundice is lasting for more than 10 weeks, and it's more than 10 weeks that he continues to have jaundice and itching. Now, Nisha had already discussed about the AKI ATN. That was the main part to discuss. But I would like to discuss a few points regarding, is hepatitis A still benign as considered earlier? Does the reach of vaccination need to be increased in children and adults with with CLD, or the use and the effect of hygiene and potable water supply on decreasing the incidence of hepatitis A in India? So this is a very latest paper from ILBS New Delhi, and look at that. There's a rising trend of symptomatic infections due to HIV infection in the adolescent and adult age group. So, out of 690 patients who presented with acute hepatitis infection, acute viral hepatitis was responsible for 68%, 31.4% patient had liver failure. Look at the incidence. Acute and chronic liver failure 0.43. Both of these, acute liver failure and acute and chronic liver failure, are distinct entities. And then overall mortality rate was 6.52, reaching 10.3 to maximum in adolescents. So the number of adults experiencing symptomatic HIV infection increased over the years, and this was shown in the present study. Infection in adolescents was associated with higher mortality and ALF as the clinical presentation. Now, the rising burden of acute liver failure in children previously was considered to be an uncommon manifestation of HIV infection. So, 48% of acute viral hepatitis cases and 46% of ALF cases in the pediatric age group are attributed to hepatitis A virus. This was one of the studies mentioned in this paper. Why? Because the seroprevalence of IgG HIV antibodies is now diminishing among Indian children, not only in the urban areas, which is only 70%. So, only 70% of urban children are protected or immune to hepatitis A. But what about the other 30%? They are prone to acute hepatitis A. And in rural, not 100%, but only 90%. So 10% are again, susceptible to acute hepatitis A. And this increased susceptibility among adolescents and adults lead to the clinical disease and severe clinical manifestations. So these are the complications of acute hepatitis A, ALF, acute liver failure, acute renal failure, blood dyscrasias, including hemolytic and aplastic anemia, and autoimmune hepatitis. Now, AKI and acute hepatitis A has already been discussed by Nisha to a greater extent, but um, um, what I'll try to focus is that in 80% of patients with ALF, AKI can be seen, and the first case of AKI with hepatitis A was reported way back in 1978, and there have been various papers that have shown that acute hepatitis A can lead to AKI. And in one of the papers, excessive alcohol consumption and diabetes were considered to be predisposing risk factors. Mechanisms have already been discussed. So, to summarize this case, hepatitis A virus infection can present with severe liver and kidney injury. ICU care and early intervention for kidney injury in the form of early appropriate volume expansion, use of diuretics and CRRT or dialysis is important. Early referral to a liver transplant center or at least an opinion is a must. Not only it can improve prognosis, but also due to legal um, uh, legal point, it can be one has to be very very sure to refer such patients if the patient's condition is deteriorating. HIV infection with clinical manifestations, severe disease, ALF, and the mortality is increasing. Earlier, it was said that HIV in children leads to anicteric hepatitis, but now it is increasing. Hygiene, potable water, and early vaccination to children should be considered, considering the increase in patients with ALF. And the take home message is hepatitis A virus infection has to be taken seriously, and the earlier view that it is a benign self limiting disease needs to be questioned. AKI needs special care, early diagnosis and appropriate management, early referral to or consultation with a liver transplant center in case of severe disease needs to be mentioned, and preventive aspects of hepatitis A need to be enhanced. Thank you so much.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this case discussion is going to help all the participants who have joined this topic, sir. Sir, as I can see, sir, there are some few questions from the participant too, sir. If you allow, with all your permission, shall we take these questions one by one?
Yes, yes, yes.
Yeah, sir. Like first question I can see. Just a second, it is getting. First question is from Dr. Subramaniam. He's asking, how do you differentiate between pre-renal AKI and instantic renal injury in this setting, sir? Could you please share some point on that?
Pre-renal and renal.
Yes, yes, sir. Yes,
Okay.
ma'am.
Sir, should I take this, sir?
Yes, yeah, please go ahead.
Okay. Okay. So basically, the line of differentiation is very blurred in ALF setting. So we need to understand the difference between these patients and other patients because everything is working. There is hypovolemia, there can be shock, there is SIRS, there is hyperinflammatory state, and direct nephrotoxicity can also occur in these patients. So the minimal thing is you need to resuscitate the patient, maintain the volume, maintain the BP. If patient starts recovering, that means patient was in pre-renal AKI. Okay. And even after that, the patient is not recovering, then you need to think that this is the renal factor and patient has gone into acute tubular necrosis. Second thing, what is available? We have simple test, urine routine microscopy. So, if in urine routine microscopy there is no proteinuria, no RBC cast, or no granular cast, then the patient is in pre-renal AKI. If there is proteinuria, that is also if we are measuring the protein in 24 hours urinary protein, then it should be less than 2 gram. That is tubular range proteinuria. Our patient was passing +2 of protein in his urine. That's why we considered the diagnosis of acute tubular necrosis, and patient was in renal type of AKI. So these two things clinically we can see. Other things are urinary kim, urinary angal. These kind of markers are not available in journal in our practice. Fourth thing, for actually perfect diagnosis, the kidney biopsy is needed, which is not possible in acute liver failure because of deranged INR, and it is actually not needed. If we are saying that this, we have established that this is pre-renal or renal kind of thing. So, if we are clear that this is because of this, then there is no need of kidney biopsy. So, the final and definitive diagnosis would be kidney biopsy. But in clinical setting, we can see if resuscitation is giving declining creatinine. If there is no proteinuria, then we can say that it is pre-renal kind of AKI.
Thank you so much, ma'am. Sir, would you like to add something to that, or we can take another question, sir?
No, we can take another question.
Okay, thank you so much, sir, for this permission, sir. We are moving to another question, sir. This question is from Dr. Aditya, and he's asking, ma'am, what is your fluid and electrolyte management approach in such patient considering risk of hepatic encephalopathy? Could you please share
Hepatic
some points?
encephalopathy. Okay,
Yeah,
okay.
yeah, Nisha, go ahead, please. Yeah.
Uh, so basically, what we are doing, we are resuscitating, but we want to maintain and decline also. So it is not like we have started the fluid and then we forget. We need to resuscitate and then we need to monitor that sodium is not inclining. We are not pushing the patient into hypervolemia. So how do we monitor? We take IVC check is very old actually. So we need to see clinically that patient is not having high JVP, or patient is not having crafts clinically in lung. And for monitoring, we can use POCUS, that is bedside point of care USG of lung. So we were checking that thing in our patient 8 hourly. So we are not pushing the patient in hypervolemia that can precipitate raise ICT in this patient. Second thing, the choice of fluid is very important. So generally we generally go for normal saline in normal setting, and in here we used KB Light A. So that is the normal osmolar fluid, that is the most physiological fluid available. We didn't go for ringer lactate as patient was having liver failure and lactates were rising. So we didn't go for ringer lactate. Otherwise, that is also a good option. Why we are not choosing normal saline? Because it can increase the sodium. And although we are trying to go for high sodium level in these settings, but hyperchloremic metabolic acidosis can occur in these kind of patient, and that can worsen the metabolic acidosis. So the choice of solution is important. That is Kbilite A, if we have that available, or ringer lactate. Second option can be normal saline while looking at chloride level. And we need to look that we are not pushing the patient into hypervolemia. If after volume resuscitation patient is not pouring urine, then we need to cut down the fluids. That is very important, when to cut down the fluid. When you need to accept that patient is not pouring the urine, now we need to stop the fluid. So in ATN setting, that is very important.
Thank you so much, ma'am, for sharing your expertise on this question. Sir, would you like to add some point, or like we can move forward, sir?
No, no, no. Please move ahead. So he
Okay.
was asking that, I mean, since patients with hepatic encephalopathy may lead to raised intracranial pressure, so I think the choice of fluid and the amount of fluid Nisha has already spoken about. We can take the next question.
Thank you so much, sir. One feedback from Dr. Subramaniam. He has written very well case presentation. Thanks for answering my question.
Thank
I
you, sir.
hope sir,
Thank you.
Dr. Subramaniam has really got information from this presentation, sir. As I can see, sir, there is no more further questions, sir. As there is no more questions, with all your permission, shall we conclude this session for today?
Yeah, 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 yeah. So we
Okay.
can conclude
And
this session.
okay, sir.
Thank you,
Thank you so much.
Nisha, for joining, and thank you, Matt Talks IJCP.
Yes, sir. And we would like to see you in future also with different topics, sir, different case presentation. Till then, take care of yourself, both of you. Like it was great honor to have you on our platform, sir. Thank you so much,
Thank you
ma'am.
so
And sir.
much. Thank you. Thank you.
Bye, sir. Take care. Bye, ma'am.